and then you go your thing, okay?
Yeah.
So chiropractically speaking, right? There's
I need 13 at least.
yeah, right. So we have 8 carpals here, but really there's only 3 we worry about chiropractically. So we've got the scaphoid at the base of the thumb, we've got the lunate in the dead center, and then we've got the triquetrum on the outside. So these, the typical thing is they can go anterior, they can go posterior. What I find is the bulk of the time, scaphoid and triquetrum, they're going to go posterior. That's the bulk of it. Now, I remember when I was in college, they would teach us that a lunate goes posterior, and you get back here and, you drive that thing forward. That's actually a very good adjustment. But what I find is that lunate, there's a secondary adjustment where you can come in from the underside and give it a lift and set it really from anterior, I guess that'd be anterior posterior and anatomical. And that can be one of the things that can help a wrist really stabilize. If you've kind of been on it, this is the typical thing, right? You get in the back of the wrist and we're doing these dorsum thrusts. And if you're seeing it this is one of those where it comes around kind of quick. So if you're on it and they're still complaining, that scaphoid, it can be, or the lunate, excuse me, it can hide. It can be not an, I've seen these where I would bet $100. This is a posterior scaphoid, right? It palpates posterior everything. You come in here and you do an anterior release and it makes everything feel amazing. All right, so I say that because that's lunate can be a little bit tricky. It can fool you a little bit. But we're going to be looking at these 3 bones. We're going to go scaphoid at the base of the thumb. We're going to look at the lunate, and we're going to look at the triquetrum. And then just like we said with the shoulder, you never look at a glenohumeral without looking at the collarbone and the scapula, right? So same thing here. You never look at a wrist unless you really take a look at the radius ulna, and then I highly recommend a small dive into the elbow. And the elbow, it really mechanically super, super simple, right? There's a hinge joint and there's a pivot. So there's 2 places chiropractically. So when you go through and you do your wrist stuff, then I go forearm, elbow, okay, we're good. But you kind of want to do 1, 2, 3, just clean that out. Okay. So Doc has had an issue. Why don't you kind of tell us what you've been feeling?
Since March, it started in March. I noticed that I couldn't do push-ups and it would hurt a lot. I had it adjusted a couple of times. Then also x-ray because I was like, this is really strange because it would just wake me up in the middle of the night. Nothing's fractured. We did that adjustment that you just said that were Doc marking me instead of the regular sort of downward, upward adjustment helped, but that pinching sort of like I wasn't also able to do this in the very beginning.
Yeah.
And it would like radiate all the way here.
Yes.
Yeah. Yes. And I wouldn't be able to do any like twisting motions like the first couple months.
Did you get to a point where you could do push-ups?
Yeah, I can do them now, but every now and then I'll notice, especially this movement will hurt, or the twisting movement.
Twisting, yeah. Close your thumbs in your fists, and then extend your arms out like this, and then point them down. Does that get you? Yeah. So, that's classic. So he's got a nasty posterior lateral first metacarpal base. So this is, so this is the base of the thumb. So here we go. So that at the base of the thumb, there it is. The first metacarpal base is right here, attaching, and when it misaligns, it goes posterior lateral. And what it does is it hangs. It's a super, super easy to palpate, right? You can know if it's just tender or if it's actually out. You take the thumb, and you're going to abduct it away from the wrist, and then extend it. Easy. So these, we'll go this side first. We'll go to the good side if you have one. It should be, let's say we put his hand like flat on a table, right? That's the position we want to start in. Out and up. That's perfect. Out, up. That's what they should do. This, you put his hand flat on a table. Out.
Yeah, that's already tender.
Up is non-existent. Yeah. And so when he was describing, I've had my wrist worked on, and this one helps, and this, but then he's pointing to where it hurts, and I go, that's a first metacarpal base. And so, but we'll see if there's anything else going on in there, because he says this has been going on for a time. So if this bone has been chronic on a patient, 9 times out of 10 the scaphoid's not right. Yeah, and your scaphoid is subtle, but that's not right. So a scaphoid, I should be able to comfortably extend the wrist. Like when the wrist comes in extension, it's just like that shoulder, right? That scaphoid should just kind of drop away from you, right? So it should drop. Same thing with the lunate, it should just drop, triquetrum. So that scaphoid drops, but the trick with this one on the inside, this one on the outside, When I drop it down, I should be able to do a deviation. So what would that be? That's radial deviation. I should be able to drop it down, radial deviation. Done. When I go here, yeah, and that's the motion. No, I drop his scaphoid down and it's not moving very well. When I try to do radial deviation, it's like non-existent. Yeah. So with this, we're going to set his scaphoid first, and then we'll set the first metacarpal base to it. Okay, but we'll do it both today. Okay, now we'll go to the lunate. Yeah, his lunate is not terrible. When I get out to the triquetrum, you feel that? Yeah. So here's another look. If you guys can see this this is a visual. When I get on that triquetrum, I should be able to very comfortably extend his wrist, right? And just feel that triquetrum just dive. Same thing now I should do ulnar deviation. So I should be able to drop it, turn it. Right on. So his triquetrum, here's his drop. It's almost non-existent and no radial deviation. So he's had his lunate set, and that's actually worked. His lunate is moving the best of all of the above. So his lunate's doing better, so we'll fix all his friends. Okay, and then we have the radius ulna. When they're happy, let's pull your watch. So these, when they're happy, these two guys, I'll go back a teeny bit. We talk about how the elbow is just a hinge, right? The elbow can't really do much else, it can just hinge. There's only one bone here, it's a simple hinge joint. But the wrist gets all of this. And it gets all of this. The only reason we have all of this is because there's two bones here, radius and ulna. And they come out, of course, and they glide. That's all that motion, is working. So radius and ulna, and if he relaxes, nice. Wiggle, 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 wiggle. So you want to see that shear, that glide, right? So same thing here, totally relax, wiggle, wiggle. Yeah, this move.
Feel the tension too.
The movement is maybe 20%, right, of what that is, yeah. So yes. So now we're going to go to the elbow, and we're going to go to the radial head first. I'll show you on the skeleton how I do this. It's kind of a lot going on, huh, Doc? How did you originally hurt this? You would tell me it hurts right there, yeah?
Yeah. Cleans. Weightlifting cleans with a barbell. I didn't feel the pain.
Not cleaning, not like cleaning the house.
That too.
I tell you, it's wax on, wax off. Yeah, so the radial head, the radial head, of course, he's what does the pivot, right? So that's the pronation, supination. So when I see someone who has a hang up at this distal radius ulna, where you can tell it's like this, it's like glue, right? It's not gliding like this. 9 times out of 10, you've got a posterior radial head. This is like these guys go, they're like peanut butter and jelly. They go together. So that radial head, 2 ways to palpate. The easiest way is you grab the wrist and you do pronation, supination, right? So you just feel that radial head and he just happy, glides like this. But you can miss a hang up. If you take that wrist and then you go into ulnar deviation. So when I take the wrist here, I supinate, and then I do ulnar deviation, you should actually feel the radial head pull away a little bit from the humerus. Okay? So he's a good example of this. If I just put my thumb here on his radial head, it's moving. He rolls in, and he's a little restricted rolling out, but the minute I try to do this radial deviation, 0. So I like adding that last component because I can tell you, not only is it meant to do this, it's also meant to glide this way. Okay. So we have on him, scaphoid, posterior lateral first metacarpal, triquetrum, radius ulna, and radius.
Not lunate, because we adjust that all the time.
It's the one happy one.
Yeah.
Okay, so first thing we'll do is we're going to do scaphoid and a triquetrum. We'll do them from the back side. So then the way I like to isolate these guys, because there's so much play in the wrist, and when we adjust these, you want to kind of take the slack out, so to speak. That's what we typically want to do. What I like to do is I'm going to grab the forearm, I'm going to isolate that bone, and I'm going to traction it open. Boom, now I own it. See, from here, I can give them a nice little set. But by isolating it, I open it up and I tuck it into a little bit of extension, I've got him. Got him right where I want him. Now we'll go to the triquetrum, same kind of thing. I'm going to isolate him, open him up a little, and is that pressure okay down? Okay, a little more. Nice, clean, clean. That's gonna make for a happy dog. Okay, so first metacarpal base, this one's a little bit trickier. This base of the thumb, of all the joints in the hand, right, this is the one that gets arthritic. And how many of our patients, if they're over 35, have some issues here? It's like all of them.
iPhone.
Oh my gosh, yes, the iPhone generation.
Poker.
And poker. So these, and I mention this because they're the traditional adjustment. Let's say, oh, this is what I learned. Oh, it's posterior lateral. So you get here with the thumb, you isolate, and you set it down this way. It's a great adjustment. It works really well. But for patients who are sensitive, you do that, and you're going to get the scrunchy face. Like sometimes it's not a feel so good. So there's a more gentle way. If you have someone who's highly sensitive or they're a little arthritic, then what I'll do is I'll put my thumb right at the base of that first metacarpal. And you notice what I'm doing is I'm pushing in and I'm squeezing in gently, right? Just giving that little bit of directionality. And then what I do, you'll split finger fastball. So I get right on here and I traction, and I'll say, is that pressure okay?
Yep.
Good. I traction and I do a lift, and this thumb is going to fulcrum it in. There you go. And it's comfortable, isn't it?
Yep.
Oh, we didn't test it before.
I just tested it out. It feels better.
Feels better, huh?
Yeah.
Yeah, you should.
He's a doctor to me. I was like, oh, let's test it.
I got talking.
Because you couldn't lift it up, right?
Yeah.
So here's his scaphoid. Love it. Look at your lunate. Dude, is that lunate happy?
Very much.
And now the triquetrum glide, they're all boogieing. And now his hand, as he puts his hand flat on it, his thumb should come out and up a little easier.
Yeah.
Yep. So we'll do that a few times, but that is a nice improvement on the on the zero.
Already.
Yeah. So now here we go to the radius ulna. We'll do the before and after. Those are my favorites. So these guys, let's go back to our normal, getting nice and relaxed. Look at that, right? Easy peasy. And that's a chiropractor. Fun side. That thing is just, concrete. So what I do is I'm going to get my thumb right in between these two. We're going to open that up, isolate that, and pressure's good there, Doc? Bingo. Bingo. So
Hey,
now,
Can you show that? Because your forearm sort of blocked that. I want to see where you put your thumb.
yes, let's do it this side.
Yep.
So radius and ulna.
Yep.
I'm going to open that wrist up a bit,
Yeah.
and I'm going to put my thumb right in between the two.
Got it.
And then I'll go thenar on top of the thumb, and then I contraction.
Perfect. Great. Good stuff.
Okay, so on a guy like, let's say on a new patient, and I may not do all this first day, right? And the patient's gonna go home a little sore, but chiropractor, he's been adjusted before. He had pretty significant rotation at radius ulna, right? What I find is, there's that syndesmosis that connects these two, right? It's a thin, fibrous sheet. It binds them together, but allows for that flow. And so he's been so jammed up here for so long. Let's sit. I usually do the sitting. Then what I do is I take him, and I'm going to do a pronation mobilization. Pressure okay?
Mm-hmm.
Anybody grow up with older siblings? I got this treatment a lot. I think this is how I got good at this. Pressure okay?
Mm-hmm.
So this, it's taking and it's kind of encouraging that end range pronation, end range supination, just doing a little bit of a dance and taking that wrist, opening it up, and it's improving that glide. It's kind of breaking up some of those adhesions that form in that forearm. And I find when you do this sort of stuff, then you get you don't get the reoccurrence. Beautiful. Okay, and then the radius, I'm actually going to adjust that with my thumb. The offhand is going to be on the wrist because I want to put the wrist in full pronation. So I want to isolate the wrist. I want to take it a little bit towards extension. And is that pressure okay? Good. I'll do a little push. Perfect. And now it should be able to come down and it should be able to open.
Thank you.
Yeah, my pleasure. That's good. That's going to feel good.
Yeah.